So, first of all, our experts, welcome to this panel. We'd like to make it as interactive as we can, invite some of the audience to participate with us. I'm going to start with a little introduction and hopefully a simple question. So, as we know, or maybe some of us don't know, 8 out of 10 adult Kuwaiti is either overweight or obese. And the rate of obesity reaches up to 40% in our small country. In 2020, Dr. Salman al-Sabah and his colleagues published the first Kuwait National Bariatric Surgery Report, looking at the procedures done in the public sector, and showed that the most performed bariatric procedure was by far the sleeve gastrectomy, followed by one anastomosis gastric bypass and then Roux-en-Y gastric bypass, with a minority of patients undergoing a duodenal switch or a SADI. Now, gastric band was popular at some point in time and fitted somewhere between a one anastomosis gastric bypass and a Roux-en-Y gastric bypass, but has since fallen out of favor. In 2013, the EFSO worldwide survey showed that Kuwait has the highest number of bariatric surgeries performed as a percentage of the national population. But nonetheless, this percentage was only 0.16%, not even scratching the surface of the obesity iceberg. Nowadays, we have multiple treatment modalities for obesities, including pharmacological, endoscopic, and newer or improved surgeries. But yet again, all these treatments are not as effective as bariatric surgery. And as I said, the percentage of bariatric surgeries performed are 0.16% compared to 40% of the rate of obesity in the state of Kuwait. Now, my first question, I'm going to direct it to Dr. Salman al-Sabah, since he's the one who published the paper in 2020. So what do you think is the status of bariatric surgery in Kuwait right now? Especially that a large proportion, if not the majority, of these procedures are done in the private sector. And these are not captured, in the national registry.
The question will be, first of all, obesity, we have to think about it, as the whole session and the program, the excellent program that you have this couple of days. Obesity is a relapsing chronic disease. And for us to understand the mechanism of obesity and the physiology, we have to make sure that we capture data and to understand what's happening here in Kuwait and compare that to the rest of the world. I think it's important that in order to have decision-making regarding the management of obesity, you need to have some data. Yes, data should be, as accurate as possible, but, giving the resources, giving the human resources as well, it's important that we understand that having a data will help us in doing planning and strategy. Now, as you mentioned, you mentioned important figures. Kuwait, as a percentage point of view, it has the highest percentage of bariatric surgery worldwide. Again, less than 1%. Now, the question is that in Kuwait, we have an excellent surgeons and well-trained surgeons that look after their patient. But the thing is, to capture the data of those surgeons is not an easy task. And this is everywhere in the world. I've been in EFSO for many years in the registry committee. And there's only 14 national registry in the world. And maybe only a few of those are a complete registry, meaning they capture most of the data. I think it's very challenging, but I recommend that we keep capturing data to understand, and that will help us not only to follow our outcomes, but also to speak to leadership in terms of you want to have insurance, you want to have, so you know the cost benefit of what we're doing. Nowadays, there is other ways of management. Maybe I will leave that for the next question. What I'm trying to say here is that registry is really important. The capture of data is important, so we can plan, have a national strategy, and more than that is looking to our colleagues from other specialty. They need to understand. I remember here when I started practicing in Kuwait as a bariatric surgeon in 2010. At that time, many of our colleagues they think, obesity as a lifestyle, right? And then it's not a disease. And there is challenges at that time. I don't want to take most of your time today, but I'm sure Professor Musa has also a lot of experience with that. He's been operating before us, and he has a lot of experience in Kuwait. So what I'm trying to say here, I think you raised an important question, and the registry is important so we understand what's happening in both private and government sector. We started the registry in Kuwait. We captured the government sector. I can say an estimate numbers. So from 2010, in the government, you're doing between 1,000 to 800. And of course, there is some time where there's a drop, and drop happens for few. For example, many of us know that COVID-19, there was only 300 cases was done, and 160 in 2021, the year after, during the COVID-19. Also, there is some political issue that happened during 2013. Dr. Musa knows about that. And also, there was a drop at that stage. So important for us to understand what's going on and manage our future. You need to have some data. Thank you for your question.
Excellent. So, Professor Musa Khurshid, so I'm going to direct the same question to you, but I'll just rephrase it in a different way. So now the public sector is doing, we know the numbers of the public sector, right? We're doing a huge number of bariatric surgery, but yet still, we're not scratching the surface. Do you think the private sector is able to accommodate this number of bariatric surgery right now or in the future? And is there an access issue where patients can access bariatric surgeries because of expenses or because of a waiting time and all these issues?
Thanks for the invitation, and I really appreciate being with my prestigious colleagues that we have seen each other many times on many meetings. So we are proud in Kuwait to have you with us, in fact. Thank you for coming. And I would like to share our experience with you in Kuwait. Let me tell you, in 1999, we started bariatric surgery in Kuwait. So I was fortunate and unfortunate to start it in the private sector. So at that time, we did the gastric banding and revisional surgery. And we had training and mentorship, etc. So we started with the band. And then afterward, we started with a Roux-en-Y gastric bypass in the early 2000s. And then in 2008, sleeve gastrectomy was introduced in Kuwait, and it became very popular among surgeons who are not able to do more difficult technique like Roux-en-Y gastric bypass. So it became much more popular. And then from that time, we had the ACUPAS, the Annual Kuwait Postgraduate Assembly in Surgery. And we started this annual meeting in 2002. And on every occasion, we were introducing the guidelines of bariatric surgery. So the number of patients were few, not as much as what you see now. The surgeons who were doing bariatric surgery was less. So we had many surgeons who were against bariatric surgery. So we had many obstacles at that time. So slowly, we started to establish a multidisciplinary team and introduce different techniques, do many workshops, invite many people from all over the world. So it picked up, and however, we were controlling everything in Kuwait, including the private sector. So your focus on the private sector. And in the private sector, we didn't do as much as what you see at present. So there was a time, although I had a lot of experience, too many patients I know, but I refused many patients who were not candidates for surgery. So what happened at that time, we had many surgeons, and then they did not respect the guidelines, the international guidelines. So it was, in Kuwait, it was like a mumbo jumbo, and that reflected on us. So people were doing 10 sleep per day, every day. And at a point, I was doing 1 or 2 sleep per week. Other surgeons whom I trained were doing 10 cases a day. So you can see why what happened in Kuwait in the private sector for the sake of money, unfortunate. So then, there was 2013, and there was an obligatory thing that, bariatric surgery guidelines should be revised in Kuwait. And this is the time when you will be responsible for whatever you do. Also, the marketing tool of, unfortunately, some of the surgeons is cheap, and it's not ethical. So what I think is that, and I urge my friend, Dr. Salman, and medical responsibility now department, is to look at this issue very carefully, because the ethical part of bariatric surgery is as important as the practice of bariatric surgery. Because you hear people talking about, I give you an example about a balloon, and they tell you about the magic blue fluid.
Blue fluid, yeah.
And that's, methylene blue. And, utilizing your marketing tools in a bad way to attract your patient is unethical, and it has to be those surgeons who practice in this way should be stopped. I mean, if you do it in the United States, you will lose your license. So I think we came to a stage that we have trained many surgeons. We're proud to say we have very competent surgeons who can do all kinds of procedures. We've done many workshops in Kuwait and so on, but I think it is important, in order to maintain this, is to have registry of our data, and we should contribute to this. And whether from private sector or from the government. At the same time, I encourage young surgeons to do more research and publication in this field, because this is how we can convince the government, the insurance, the society, that this is a good way of avoiding complications of obesity. So I think the future need to be tuned a little bit in terms of ethical issues, research, and publication, so we get respected much more as surgeons in bariatric surgery.
Okay, excellent. So I'm going to ask Dr. Mohammed Jamal a question now. So do we have, so Professor Musa Khorshi brought up a very excellent point. The way, let's say, marketing works in Kuwait depends a lot on social media, and ethics are not governed by anybody but by yourself, right? So you see a lot of variability how people market these procedures or these different interventions, right? And then I'm going to come to our visitors and ask them to reflect on this experience from where you practice.
Well, they practice in Abu Dhabi as well, before going to the US, so they know both worlds.
Yeah, well, there you go, right? So it's going to be perfect. But so the question here is, do you think that's one of the reasons that are we losing the public trust? Is there an issue where people don't trust the surgeons or don't trust their doctors to provide them with the best treatment possible, especially that most of these surgeries are done in private sector, right? You're asking the patient to pay for the service, and the way some of these advertisements are shown may make us look, or as a collective body, like not trustworthy.
Yeah, I think this is a very tricky question to answer, but I think we are losing the public trust as a medical community because of other issues. I mean, the social media, it's more philosophical. Like we thought that when the internet comes, it will strengthen science and facts. But what happened is the internet became a platform, especially the social media, became a platform for those who are not specialists. This is the age of anti-specialists in general. And what happened in COVID-19, especially in Kuwait, the anti-vaxxers movement is one of the strongest in the whole region here in Kuwait. And they are continuing to hinder the public trust in the medical community in general. The other issue is the stigma against obesity. It's extremely strong in Kuwait, although 50%, or 40% of the population are obese. The stigma is very strong. In the private sector, because we don't have brands, not in the government, not in the private, we don't have brands in Kuwait. And we don't have sources of referrals. So your referral is your social media page. We don't have regulations from the licensing body. Like they don't license you to do bariatric. Anybody can go there and start doing bariatrics with minimal training. So the public is not aware of what a bariatric physician is or a bariatric surgeon is. And therefore, your public page on Instagram, for example, can allow you to do whatever you want. And this is the real problem, the Kim Kardashian factor, right? So Kim Kardashian has more impact on the scientific facts in the world than the New England Journal of Medicine, because in her account, if she puts something, it will impact the world much more than the New England Journal of Medicine. We live in a different world, and it's extremely difficult to navigate through that world.
Okay, so good, Dr. Kochil, how let's reflect on that, like in comparison to the US or Abu Dhabi. Are the same issues are faced there? Is there a problem with access of patients to bariatric surgery, whether it's monetary, whether it's an issue with long waiting times? Is there an issue with recruiting those patients who deserve bariatric surgery? And in a comment on Dr. Mohammed Jamal's comment, Dr. Professor Musa Khurshid, is there a mistrust in physicians because of some of the people in the medical community do not represent as well?
No, thanks for the questions. I think that I can give you my view from my earlier times in Abu Dhabi, at the Cleveland Clinic in Abu Dhabi, and now in the US, right? I think that the UAE and more specifically Abu Dhabi, in some way, the problems that you are pointing out now are pretty similar. I mean, the lack of probably understanding metabolic and bariatric surgery, the mistrust on the medical community and surgeons, and those are the main similarities in between what I witnessed in Abu Dhabi and what I can see you are facing here. Probably the main difference in Abu Dhabi and Kuwait, as far as I know and I'm aware about, is that I think that Kuwait, and I think that I have to praise the three of you that are sitting here, Professor Musa, Professor Al-Sabah, and Dr. Jamal, is that you've been for many, many years trying to implement and trying to actually report your own data and train your own surgeons. I was really, my first time here 5 years ago, approximately, or 6, I was kind of impressed about how ahead you were from the UAE at that time, sending fellows to the US, to Canada, reporting your own data, trying to submit publications. So I think that from that point of view, you are doing a good job. Then, patient access, of course, the US is a different story, right? And I think I will let Dr. Crow to dig a little bit more on the problem on insurance and the lack of access for all our patients. In the US, of course, we have a lot of support by our scientific societies, the ASMBS, the American College of Surgeons, and that, to answer Mohammed's concern here, that gives us a lot of credibility. And I think that those are the main things that I can tell you comparing both settings. But I would like to let Dr. Crow to dig a little bit more about the US problematics.
Yeah, I guess, Dr. Crow, the US comes with its own set of challenges since it's an insurance-based health system. And the issue with access would be, like there is another obstacle, I guess, because of insurance and the coverage, and it's one case you get to do and it has to be perfect and that's it, you don't get another one, right?
In some ways, yes, that's true. So there is government insurance and then private insurance, and that covers the vast majority of the country. And the way that bariatric surgery has been covered is that through public reporting of outcomes and ultimately centers of excellence designation, certain complication rates are expected, outliers require reevaluation, and certain centers have closed because they are outside of those parameters. But once the government payers have identified what those outcomes are, the private insurers also cover that. So in some ways, it's a very large system that includes public and private insurers, but they all follow the same guidelines. And what that has done is allowed a huge percentage of the country access to bariatric surgery. There's actually very little self-pay bariatric surgery done because the majority of patients, either through government or private, and private is usually provided by a place of work or where they're employed, are covered by bariatric surgery. It wasn't easy to establish, and it took years to come up with this, but basically public reporting of outcomes identifies the centers doing the best work, and then the payers, either private or governmental, follow that and then allow access to surgery. So it covers a large percentage of patients in the US. And then to comment on the social media presence, we realized this when we were in Abu Dhabi, and we published a paper in obesity surgery that looked at the 3 most popular web-based search engines. One initiated in Abu Dhabi, one initiated in Cleveland, Ohio in the United States, and both English and Arabic, and queried obesity, obesity surgery, bariatric surgery. And we used a scoring system that Dr. Corsellis used in Barcelona, looking at the quality, the medical quality of those websites. And overall, the quality of the medical knowledge from those sites was quite poor in both sites, but much better in the United States. And interestingly, the majority of those websites in the US were from hospitals or academic medical institutions, whereas in Abu Dhabi, and it didn't matter if it was in Arabic or English from the United States, and it also didn't matter if it was in Arabic or English from Abu Dhabi, but the vast majority of those sites were from private hospitals or individual surgeons. So I think that's a huge way in which patients identify who's going to do their surgeons, and an opportunity for us to increase the quality of information that's available to our patients, because they are looking it up and they're getting different sources of information depending on where they're looking from.
So the lack of a reliable source makes the only source for patients is whatever I put on my Instagram page, right? So they look me up, and then whatever I said, since I'm a doctor who self-identify as a bariatric surgeon, because they cannot validate this anyway, right, is the information they'll get, right? And that's, I guess, part of where the mistrust comes, because you can see even variation in the information are given by different surgeons, like Professor Moussa Khorshid was mentioning. Someone would tell you that this blue magical fluid will make your weight go down, when it's just the fluid we put in a balloon.
And that's an extreme example, but we know this. There's variability in the data that we even generate. I mean, we can talk about different expected weight loss outcomes from sleeve gastrectomy or ESG and not come up with a consensus here. And then how do you translate that very complicated conversation to patients who want something innovative and less invasive? And it's a slippery slope to start to say that the methylene blue is a magical elixir for weight loss, but how about Botox into the pylorus? There's a spectrum as to what that looks like, and it's hard to make that answer simple for patients to understand. So I think that developing resources that are truthful, based on data, easily accessible to patients, and a small number of resources that aren't self-promotional should be a goal of social media or online resources.
That's an excellent point. Okay, so let's steer a little bit away from this, and let's talk about the recent guidelines that's published by EFSO and ASMBS, the joint guidelines. Now, the guidelines that traditionally bariatric surgeons have followed were published in 1991, and the only real update we got was a year ago, right? Now, are we catching up with these guidelines in Kuwait? Because the guidelines basically increased the number of patients who would be eligible for bariatric surgery, allowed for more decision-making by multidisciplinary teams who deserve bariatric surgery, as opposed to just a very harsh number. If either your BMI is 34 and you are on 3 medications of diabetes, you don't deserve bariatric surgery. If you have joint pain and BMI is 35, then you get bariatric surgery. Right now, there is a bit of a discussion and a multidisciplinary team approach can recommend bariatric surgery even outside these parameters. Now, are we catching up with these guidelines in Kuwait? Do we need the government to put forward these guidelines for us to practice? This question is for you, Dr. Salman Sabah. Or in Kuwait, do we have the authority or the autonomy to follow these guidelines and because they're international guidelines and from a well-recognized authority?
Right, so this is a really important question. As you know, when you work in Kuwait, you have to follow the regulation in Kuwait. Same thing in the US or in any other country. However, as a society, you need to make sure that you are up to date and you influence the leadership at the Ministry of Health to change the guidelines. And because these are guidelines at the end of the day, they are not like strict rules. But when the ministry put them out as a decree, qarar wazari, then we have to stick with them, right? So making sure that the guidelines is updated and making sure that people are involved from bariatric surgeons involved in this. Because, you know, I'm sure there is many attempts to, you know, put a new guidelines, but we need to have good follow-up with that. And this is a priority for, you know, societies here in Kuwait to follow on that. And you have a guidance from either the ASMBS or IFSO. They recently, both of them, came up with the guidelines, new guidelines. And I'm sure maybe even in 5 years down the road, there's new guidelines. So we have to be updated and then reflect that in Kuwait. Now, following the guidelines is important not just because of BMI, because for other reasons. So as an authority in Kuwait, AMR, we are obligated by law. So we have to make sure that as a health provider, you follow not only looking at BMI, but other factors as well. And all this leads to safety to the patient. Also, making sure that the surgeons have, you know, when they follow the guidelines, hopefully we have a better outcome. Now, just to come back to your first question about access, private and government, I think, yes, you mentioned we have the highest percentage of penetrance to bariatric surgery, but I think education and training and having a national registry by the society, making sure that other specialty are involved. Today, obesity became a specialty. There's a board in obesity. And I remember when we started, myself, in Amiri Hospital, we used to use the instruments from the hospital itself. You know, because when you do appendectomy, you use a stapler, right? And maybe ligashur. Why not on bariatric patients? Who prevented that? Is it someone who came and told you, don't use it? Is it by a decree? Or is it because of people used to listen to other people and then it became a habit? This is an important question. So when you say access, the government allows you to do bariatric surgery in the operating room for free, right? Your hand work is free. The instrument, when I started, was free, right? Because in the government, you're doing 1,000 cases a year, 5 staplers, if you're doing, that's 5,000. Do the math, you know. So I don't think so it's a budget issue. It's about how you allocate that and how you speak this language to people in the hospital. But with time, that changed. And I was there, and we asked patients to get the instruments, right? So I don't want to deviate from what you just said, but just to go back to your question. So I think what it tells us that surgeons should be leaders in this aspect. We need to make sure we are involved in committees, having decisions making, and making sure our voice get heard by people who do the decisions. It's important for that.
It's funny because this was my last question, but we can bring it up, is that none of the obesity interventions available. We have all the obesity interventions available in Kuwait. So we have pharmacological, endoscopic, and surgical. We have excellent dietitians. We have excellent exercise physiotherapists and physicians. And I was in Sages in Montreal a few months ago, and it was like people who talk about medication and how they work. We're like 5 of us. Like it's a foreign language, right? It's like 2 people from the U.S., 1 person from South America, and me. We're the only people who talk about medications. Most of the world don't have access to this, and we have them all. However, especially that you brought it up, is that patients are paying for their staplers in the hospital. That makes there is not a single intervention of these interventions is provided for free. And that does provide a barrier for access to bariatric surgery, to obesity treatment in general.
Right, so again, who prevented a free instrument to a patient? If you can show me any document, I would like to see that. But at the same time, we need to discuss that. Who decides on obesity medicine to be distributed in Kuwait? Is it the surgical departments or it's the medical department? It's the medical department in Kuwait who decide about medications.
Correct.
What is the role of a surgeon? Question mark, right? Should surgeons now prescribe anti-obesity medication? This should be discussed. We're going to have a long session about that, but at the end of the day, we have to think if you're doing obesity management from all perspective as a holistic approach, then you do only obesity because it became a specialty now. So you do surgery, you do endoscopy procedure, you do medication, versus you depend on endocrine or medical physician to do that. Now, all these questions should be discussed in a professional way, and there will be guidelines for that, depending on your training, on your education, and so on.
And I take your point that it's the responsibility of societies to put gentle pressure and put forward these suggestions to the leadership and make them
This kind of meetings, what you're doing right now, I can see a few physicians are around here and surgeons. This is how we start discussion. And, I'm sure we're going to have a better access with that and understanding but first, it all comes back, if we all agree as health providers, obesity is a chronic relapsing disease, then we go from there, right? So if there is, especially from the other specialty who have a good relation with the pharma side, right? So it's important to have that dialogue.
Perfect. Professor Musa, I'm going to steer the conversation a little bit different. Just recently, the group in Vienna by Professor Prager published their 15 years of experience with sleeve. Their 15 years outcomes, very solid data. But what the data shows that almost 40 to 50% of these sleeves had to be converted, whether down to a sleeve or a SADI or a DS, mainly for either for reflux or weight regain. Now, the most common procedure done worldwide and in Kuwait is a sleeve gastrectomy. You mentioned you guys started doing sleeve gastrectomy in 2008. We are at our 15 years mark now. Do you think we're going to follow the same path?
Well, sleeve gastrectomy, no doubt, is a good operation. I mean, it has a long-term outcome. If you compare it with Roux-en-Y gastric bypass, I mean, look at the CRIS2 study, 10 years follow-up, 40% failure. I mean, all bariatric surgery fail. And this was one of the discussion regarding endoscopic sleeve gastroplasty. I mean, tell me one single bariatric procedure that do not fail and then they don't regain weight.
It's just how
and
fast
they get reversed. Yeah, I mean, the reason sleeve gastrectomy became popular in Kuwait and all over the world because it's easy from technical point of view. And now many surgeons, they know how to do it properly. So that doesn't mean, that study that we should not be doing sleeve anymore. No, we should improve our follow-up of our patients. We should improve our multidisciplinary team. We should think of a better way of revising those patients, failing patients, and follow them properly. So that's an issue. beside this, I would like to comment on the guidelines that you have mentioned just now. I think it is important that we as surgeons do not stand in the way of others. We should support our colleagues, and we should always encourage any new technique that come up in the world of obesity surgery. So I would encourage young surgeons to go for IRB studies, to publish their data, to look at their patients, even new techniques. We went through difficulty when we were doing the endoscopic sleeve gastroplasty. Now we have done how many cases? 400 patients. We published them in IFSO just recently. And we had reasonable data, which is not different from the rest of the world. So many people are adopting this and so on. So I think a new technology is important, but it has to be monitored if we want to implement it in Kuwait. So when we started with the ellipse, it was not approved by the FDA and so on as a device. However, we had very good outcomes from the ellipse balloon. They modified the technique at the beginning. We had problems with the valve, etc. You remember Dr. Salman. And now you see the ellipse balloon is preferred by many surgeons in Kuwait. So I think we should not stop against innovations in instruments and techniques and so on. And we, however, if we want to implement those innovations, it has to be done in a scientific way and as an IRB study. That's my recommendation. That's my advice for people.
It's perfect.
Yeah, a couple of comments. First, regarding your previous question about the new guidelines. Now, I think that all of us surgeons, we got super excited about the new guidelines. But at the end of the day, I think that Dr. Salman, he is right that we as surgeons and our leaders in the surgical societies have the duty and the homework to go to our insurers and explain why these new guidelines are needed. Because if they are not implemented, at the end of the day, we are like the 1991 NIH guidelines, which, by the way, were written when the laparoscopy era was not there, were based on patients that did undergone vertical banded gastroplasty, et cetera. So those guidelines were absolutely out to date. No? So I think that despite our excitement, I think that we have a lot of homework to do. And we at the Cleveland Clinic, and Dr. Butch, I think he's also leading the group that is trying to discuss with our employee health plan managers to make those guidelines to be executed, actually, to be sure that our co-workers can benefit from them. And then the second question about the sleeve gastrectomy, I think, and I know that manuscript, but I think that we have to be careful about the data, no? I think that there's only one randomized controlled trial, 10 years follow-up on sleeve gastrectomy. And the data at 5 years is surprisingly very good. And I'm saying surprisingly because now these 40% revisions, I think that it is a little bit over what the reality says. So I think that we need to be careful. Again, agree with also Professor Mosa, but regarding the sleeve, I think there are a lot of other questions behind, like the easier technicality when you indicate revisions, etc. Thank you.
Great. I'll give the last question to Dr. Wanjan. I'll come back to Dr. Crow. So we do a fair number of revisions. Do you think this is going to be the future for us? This is going to be the future of bariatric surgery in Kuwait?
I think the future in terms of revisions is medications, right? Because I think it's the same.
For weight regain.
Yeah, for weight regain, except for reflux. I think we should embrace the medications. We have prelim data on the Mounjaro following weight gain after sleeve, and The results are very effective. Maybe starting the medications early. We need to, Dr. Crow today mentioned a very nice concept when we were talking at lunch, disease-free survival. So he said we need to think of it as the same as in terms of oncology terms. So we can use adjuvant treatment, the medications, or neoadjuvant even. Sometimes we use it before the surgery, right, in the super high BMI. Yeah. And maybe start the medications early in some of those patients, monitor them very regularly, inform the patient, tell the patient, I need you to follow up, not only to see that you are doing well, so that we can start the medications early. As soon as you start even minimal amount of weight regain, we need to start some interventions. And I think that's the key in preventing the weight recurrence after bariatric surgery. Early monitoring, early use of medications, and that will reduce the revisional surgeries. My volume of revisional surgeries is reduced tremendously since I started getting hold of Mounjaro. Of course, patients might regain after the Mounjaro. However, this is something to be seen. Maybe we can create new strategies in terms of nutrition and exercise, and that can help in maintaining the weight even after Mounjaro, after weight regain post-sleeve.
All bariatric surgery has been reduced after your social media platform on Mounjaro, not only revision and surgery.
So, Dr. Crow, that's an interest. Do you think, so I believe in the same concept, well, I'll take your point. So you think medications will change the shape of revision surgery? And is there an issue? Well, right now, we know in the pipeline, the next 5 and 10 years, there's multiple combinations going to come up. It's going to be extremely effective. The issue is probably not going to be different than now. Access to medication, not only availability, but the price of these medications is pretty steep.
Yeah, all that's going to change. And I think that as surgeons, foolishly, 20 years ago, we thought that we were curing diabetes with an operation. And we've promoted this, that surgery is very effective for putting disease in remission, but all we're trying to do is shift the curve to the right. Correct. We're trying to limit the number of years that patients have obesity and weight-related comorbid disease so that the cumulative impact of having diabetes, having cardiovascular disease will be limited. And whatever combination we need to do that, whether it's surgical, endoscopic, medication, in the order doesn't matter anymore. So if there is a significant percentage of patients that have sleeve gastrectomy that have weight recurrence or weight gain, that's okay. There will be some other intervention, medical, surgical, that will continue to shift that curve to the right. And if we can make sure that we limit the number of years, especially for our youngest patients, for the pediatric population with severe obesity, adolescents, young adults, how do we shift that curve to the right for as long as possible to keep them free from these chronic diseases? Because we know it's those cumulative effects that will ultimately affect their morbidity and mortality. And that answer is always going to change. It will not be a progression from lifestyle to medication to endoscopic to surgical, but some combination of those that needs to be designed for each individual patient.
Okay, very good. Okay, it's very interesting. So, and I agree with this concept. To me is fascinating. Is that people, when they come and discuss, we know a lot of people who did the sleeve gastrectomy or did whatever general surgery and then regained weight, and we saved them 10 years of bad hypertension, severe diabetes, poorly controlled hyperglycemia, and that and so on is a success. Now regained, let's revisit that and retreat it again. Okay, I want to open the platform to the audience. If anyone has any questions before we proceed with the session. Huh? Okay. Yeah, can I get you? Do you have a?
Yeah, Dr. Shab, if you allow me, IFSU last year in 2022, I gave a talk on, Scott Chikora spoke about a topic which is called ABCD, which is obesity reworked as adiposity-based chronic disease, okay? And then I made comment on this, I made a presentation. Now the future is going to be not in the hands of surgeon. Obesity surgery is going to be in the hands of internist, of those who are specialized in obesity. And then we, as obese surgeons, will be receiving those patients from those. This is what is happening. This is a trend in the United States, and this is how you will be covered by the insurance. So, it's not us that who is going to prescribe Manjaro. No, we can promote it, yes, sure. So I think we have to be part of this community, and it is coming to us. And in the future, I think this is the only way that we can go in the right way in Kuwait, the future of bariatric surgery in Kuwait. Now, those, obesity specialists who will refer those patients for you could include internists, endocrinologists, et cetera, et cetera, et cetera. Scott was against this concept, of course. He would like to have the control, we as surgeons would like to have the control under us. However, there are, this is published by the American Endocrinology Association, and it's been published in 2017. It's about 1,037 reference in that publication talking about the future of bariatric surgery and obesity treatment. That's a comment.
Excellent. Well, I agree the concept of multidisciplinary approach and multidisciplinary team in treating obesity is important, but a surgeon can also be an expert in obesity medicine, or at least tries to be up to date with these concepts. Dr. Shab. Dr. Khalid
Hi, my name is Khalid Yagum. I'm a bariatric surgeon trained in the UK. Just a quick question. So if we would invest in the future, should we invest in more bariatric surgeons or more bariatric physicians? And it's a bit philosophical. Would we get more obese patients and hence we're going to need more bariatric surgeons and physicians, or would medications actually cure it to an extent where bariatric surgeons won't be as required as nowadays at least?
I think bariatric surgeons will always be a part of this equation, but if you look at, Scott, how many obesity medicine physicians are there in the United States? 5,000. So in a population of nearly 500 million, to have 5,000 physicians who are board specialized in obesity medicine probably severely underestimates that need. Now, there may be components of internal medicine or endocrinology, but there needs to be more training in that space, because patients should come to all of us for treatment of obesity. It doesn't matter what mechanism they're going to get. They should come to a program for treatment of obesity and then let the experts in that program figure out what series of steps will be appropriate for them. Because otherwise, if you go to a surgeon, we're going to be biased toward offering that patient surgery up front. And that may be the right answer. Often it is, but it may also not be for medical reasons, for psychological reasons, for nutrition reasons. And if you don't have a comprehensive program that can offer all of those interventions, you may not give that individual patient what they need the most. And I think that probably in the US and then probably worldwide, there's a greater need for obesity medicine specialists than surgeons currently. But we'll still be needed.
My question that this session was about the future of bariatric surgery in Kuwait, and I thought that most of the discussion will be about the future. I thought that we're going to discuss the registry of bariatric surgery in Kuwait. We published once in Kuwait, the registry, and we don't have any registry anymore. And I think we should go back and work on that and publish our data again in Kuwait and make a use of it to all the surgeons that practicing surgery in Kuwait, especially bariatric. Number two, I think Kuwait, this small country, has the highest number of bariatric surgery being operated every day compared to all the other countries in the region, and I think maybe in the world. Regarding that, I think we should have our own guidelines for the bariatric surgery. I think the We should all gather together, most of the bariatric surgeons, the society, surgical society, and collaborate with the obesity physician in Kuwait and get a data and guidelines for Kuwait. I think we have really good data. I think the standard of surgery and the standard of care is really good. That's why we should have our own guidelines, number one. Number two, we should have our own standard protocol for obesity surgery in Kuwait. And I think this is the right time to do it and establish it in Kuwait. Thank you.
Excellent. I think we've touched on both these points. Dr. Salman Sabah eloquently discussed this, that the registry must go on. I think the issue here is that how do you combine the registry of the public sector that is already established, and how do you create a new registry that will factor in what's happening in the private sector? Because right now each surgeon is almost operating in isolated silos, right? And we don't have these numbers poured in one registry.
So I think all these are important points to consider, and it tells us that we are on the right track, that we have to think about these points. The question will be, we need to collaborate, we need to work together, we need to make sure that we get involved. Sometimes you get busy with life, especially if you're in the private sector, been there for 7 years, it makes you busy, right? So we need to give some time for some admin work plus research to make sure that we are, up to date with our registries and with our protocols. Technology is getting better. The access for technology is there, but we need to have dedicated people for that. So the issue is that you have to have a registry manager, and you need to have people, and that's equal cost. So when you have people just focusing on registries, and you have to keep, when we discuss this in EFSO, a minimum $1 million on a site when you want to do a national registry, because there is a cost for people running it, a cost of people to update, to verify, and so on. It's a complex procedure, but a complex way of doing things, but it's important. The benefit, that will help us with our national registry, with our national strategy, and so on. Now, the future of bariatric surgery, with how I see it and my personal view, is that I agree with both Professor Musa and our colleagues here that it will be a combination of different treatment. But what's important, you have to think about it from patient perspective. How we can give our patient the best outcome is you have a patient that go to a safe facility. They have all the discipline in that facility. You treat the patient in a holistic approach. If you take a patient to a below standard facility, the patient might injure it. And then, the sequelae of, we're going to discuss this tomorrow in my lecture about malpractice, but, all these are important. And if you want to discuss more, like today, tomorrow we're going to discuss about I'm going to touch on insurance and how the court look at obesity. And recently, the court have a final ruling, court of cassation, so the final court in Kuwait, considered obesity as a disease. This is really huge, okay? And because the insurance, refused to cover a surgeon who has a malpractice in bariatric surgery because the insurance considered bariatric surgery is a plastic surgery. And many physicians and colleagues, they still think, this is some sort of plastic surgery. It is not, right? So education and, social media, there's an article in New York Times, I still remember it, and it's encouraging, physicians to be on social media to make sure they give the right information. And our new law, which we're going to discuss tomorrow as well, says that you have to discuss that, but in your specialty, in your field. So if you want to discuss about certain, disease, it should be in that specialty. There's something like, there's few topics that any physician can talk about, general medicine, but if you go to more subspecialty, then you have to have that degree for it. So I think, again, awareness is important. And prevention, prevention, one part of a prevention is registry. So you need to know what's going on in your country to prevent what's coming. And what's the cost of all that? At the end of the day, there is some numbers to be calculated to make sure that you have the right medication, you have the right equipment. Because just say we don't use bariatric procedures in government hospital or instrument because it's costly. Show me the data, right? So I think the future will be near future. 10 years from now, it's difficult to predict. We're moving so fast. But at least with the 5 years coming, I think it will be a combination. I agree with the panel that it will be a combination of treatments. But what this tells us, we are going to personalized medicine. So each patient, he has his own genetics, he has his own body habitus, and we have to treat him accordingly. And that's by utilizing all the information that we have and his response rate and everything else, and then decide what's the best treatment for him in a multidisciplinary team. So that's why it's important to have the right facility, the right people, the right hand for the patient, to make sure that we have the best outcome possible. But if we just say it will be medicine only or surgery only, I think that's not the case. Maybe medicine will be for lower BMIs, and when BMI 50, because that's why when I said at the beginning, obesity is a chronic relapse disease. It might relapse, whether with medication or with surgery. So that's why it's a chronic disease. You cannot say the future will be only medicine, because I'm sure there will be BMI of above 50 that no matter medicine you're going to use, you will not reach your target, right? Correct. So I think it's a combination, individualized, personalized medicine. That's the future.
So highlighting the concept that treating obesity is like treating cancer, and like any other cancer case that you have to bring in front of an MDT, obesity should be treated the same. Thank you very much. I would open the floor to any final remarks.
I'll just make a final remark.
Yeah.
It's going to be quick. So I take this opportunity to thank the CAS, Kuwait Association for Surgeons, to support the establishment of Kuwait Society for Metabolic and Bariatric Surgery. So thank you, Dr. Shab. Thank you, Dr. Salman. I am honored to be one of the members, being invited to join. And I promise you that we have a lot of things to be done in the future. We are going to implement whatever we have talked about just now, and the future is going to be better. So with the collaboration of our registry, with Dr. Salman and so on, we have to make Kuwait better. And this is our wish, and that's what I see Kuwait in the future. The future of Kuwait is bright. We have one of the best registry programs in the world. We have a society that now supports the development of a new association, the Kuwait Society for Metabolic and Bariatric Surgery, and we will see more work in the future. We'll see more suggestions to all the departments that do bariatric surgery in Kuwait. That's my comment.
Okay. Thank you very much, our speakers. Thank you very much for listening. Have a good evening.